I need it to stop. I need everything to stop.
I'm sorry that I'm not a person anymore. I'm a problem.
Because I thought that if I didn't find help right away, I was going to kill myself.
Medically, socially, personally, this entire field, this huge part of everyone's lives is always treated as not real. And because of all that stigma, we end up not talking about it, and we end up hiding, and we end up being ashamed of it, and then a lot of people just don't really end up getting help.
This is the first time that mental health was a major topic in the Middle East Medical Assembly. Mental health issues can be found everywhere and every day, in the schools, in the workplace, in the hospitals, in the colleges, and affects all kinds of people. So there's a general interest in mental health. There are also a lot of misconceptions about mental health. So we wanted to invite the public, and we wanted also to give a better understanding of mental health to the people.
The fact that Lebanon has continued to hold such an event at this scale, despite all the difficulties through the previous years, I think, hats off to that. It genuinely says a lot about the extreme interest in making sure the fight for science, the fight for health, and to maintain that level of exchange and training ongoing.
This conference focused on mental health across the lifespan is revolutionary, that this is something pretty new for this region to address this openly. The video of the lead singer of the rock group talking about sexual orientation as mental health issues, these are kind of revolutionary steps. So it seems like this is going to explode across the region, that an acknowledgement of mental health as part of health generally is going to grow, and hopefully some acceptance, some destigmatization.
Well, first of all, I'm impressed by the academic mission and the social conscience of this place. I mean that as far as AUB is concerned, but also the MEMA conference. The fact that mental health was the topic chosen among the platform of internal medicine and reaching out and educating a lot of clinicians is very impressive.
Mental health, as it was really shown up during this meeting, it's very important and it's very prevalent. The prevalence of mental disorders, or at least issues that we face in the region, is tremendous. And this is why the attendance at this MEMA has been really significantly high, because a lot of people are interested, and this affects not only people in that specialty, but also in other specialties, in people who are dealing with just regular pediatric population and general population. So the mental health issues are underscoring a lot of different disciplines, and this is why it was important to address this in this MEMA.
Mental health problems are a very common problem in the Arab region. Main issue is that people who suffer from a mental health condition in our part of the world do not seek treatment as much as people do in other parts of the world. And that's our problem. And it may be because they don't know that they suffer from a mental illness, or they feel ashamed to seek treatment for mental illness, or they have no access for treatment because it's not available.
I was invited as a speaker to talk on a panel discussion about mental health research. So the talk will be mostly about the challenges around mental health research in the Middle East, the extent of research we're going in the Middle East, and how to promote more research work, how to create the time for more research work in this part of the world.
So it was also really nice to see Arab mental health researchers come together in a symposium this afternoon and discuss challenges that are encountered by researchers when they're involved in mental health research. And there were also opportunities to discuss some potential solutions to these challenges.
There's a significant interest in doing research, but to be very frank, in my experience working in this part of the world, that this interest is not always reciprocated with an equal level of training in research. So people may be very keen to do research, but they don't have the background training of how to do proper clinical scientific research. The time is another challenge. In many parts of the world, there is a time that is dedicated for research. We don't have that. The understanding in the Arab world is you're doing research on me as if you're experimenting on me. It's always equated to experimentation. And the moment you use the word research, no, I don't want to be experimented on. So you need a lot of education around what research means. I think as hospitals, as colleges, universities, we need to make sure that research is embedded genuinely as part of our daily routine.
Mental health, in the final analysis, is a function of the brain, which is an organ of the body. So it's important for people to know that it is malfunction of the brain. So that puts it into the realm of medicine and diseases. And this is one thing that we wanted to have people understand, because when they have mental health issues, okay, they try to solve it in ways that is not going to help them. But if they seek the right people, the right physicians, the right nurses, the right psychologists, the solution will be much better.
We're coming from historically, neurology and psychiatry were different disciplines. But I think gradually it's becoming very clear that there is really no distinction. It's all brain disease. Okay, so there is nothing psychological, there is nothing mental. It's all science, it's related to neurons, to synapses, tracks in the brain.
A lot of the diseases, MS, Alzheimer's disease, Parkinson's disease, do that often. Of course, they may not be apparent in the beginning that they are neurological diseases. But a good person, a good psychiatrist or a good neurologist realizes that a patient who's presenting for the first time ever with a depressive illness, he may be hiding some other neurological illness.
Mental health, including depression, anxiety, can be part of the disease manifestations and also can make your relationship with the disease different. For example, people who are depressed respond not as well to medications, and treating their mental health issues will improve the prognosis of certain diseases.
We know that patients that have, for example, cardiac disease or patients that have diabetes, they are going to be having a difficult time adapting physically to those new diagnoses, but we know that they're also at risk for emotional stress. And a lot of that can be depression, it can be anxiety, it can be bad behaviors as far as taking care of yourself. And the best way to address those illnesses is a combined product. You have to look at the physical and you have to look at the emotional health. Coming from the States, and I would say, part of my experience also in Europe, is that for too long it's been farmed out, it's been fragmented. We focus on the physical, but the emotional is an afterthought, or people aren't trained. Both the patients and the clinicians are not trained to address that properly. So I think that's one of the missions, and that's one of the goals that we have in bringing my colleagues from the Cleveland Clinic here to learn with you, but also to show how we try to raise that awareness among all the people involved.
Because unfortunately, sometimes, be it within the professional bodies or within the public, people may believe that if they can't see that the person is in pain because he or she doesn't have a bruise or he or she is not bleeding, then this person is healthy. And we all know that mental pain doesn't always show. This is one. The other thing, at this point, psychiatry as a medical specialty is in the process of identifying what we call biological markers. We don't have blood work to tell us that this person has a mental illness the way we have it in diabetes, let's say. We don't have imaging or brain scans that tell us that a person has a mental illness the way, brain scans show you that a person has a stroke or a bleed. So this is one of the main reasons why people believe if they can't see it, it's not happening. So we're trying to tell them, if you don't see the pain, it may be there, and if it's not physical, it's emotional.
We have to be very sincere. We're training internal medicine doctors today in some of our training programs that have 0 months, weeks of exposure to psychiatry. And so what happens is that they're not comfortable in having those conversations. And so when they look at the findings and there's no physical findings, they're going to move that person on to another specialist. And it's a missed opportunity to engage that patient, to have that conversation, to validate saying, look, we didn't find the physical symptoms, or maybe we didn't find anything on the x-rays, but what you're experiencing is real. Furthermore, it's affecting your quality of life. Furthermore, let's start talking about how we can tackle this or we can treat that. So those are missed opportunities. And you and I know that there's a little bit of resistance to getting mental health, right? And so people don't want to go to the psychiatrist, And so that's part of our challenge, but also our opportunities to educate all clinicians, at least in the basics of mental health and how important it is, and teach them how to have that conversation.
There is a close relationship between mental health and physical health because people with physical health problems are more likely to suffer from emotional distress, and hence they're more likely to have mental health problems. And the psychiatrist has to be aware of the physical health of the person, and the primary care physician has to be aware of the mental health of the person they're seeing.
That's critical, that you spread the message that the aspect of emotional health is, first of all, real. Second, it's treatable. That's the key thing. And when people understand that it is something legitimate, and also that there's treatments for it, that starts to break down a little bit the stigma. That starts to break down a little bit the barriers that are involved in getting that care.
I've been delighted to take part in 3 different sessions. The first one I took part in was the school mental health session, and I presented work from a school-based study that my co-PI and study team in Haiti and I had collaborated on and just wrapped up recently, so we presented findings on that, and that was directly relevant to some of the work that I'm collaborating with Dr. Malouf on and the school-based study here in Lebanon.
Mental health problems are common in college kids, and that's due for many reasons. The transition to college is not an easy time. The age around which kids transition from high school to college biologically is also around the same time when psychiatric disorders start. It has to do with development of the brain. I have a lot of conditions that appear around that time. For example, schizophrenia, bipolar disorders. A lot of studies show that this is the time when they do actually appear.
Higher education, mental health in the United States, really looking at themes of more and more students coming to counseling in the US, but it's also true here in Lebanon, as I heard at the conference. It's also true in Australia. It's such a global, international phenomena where college students are seeking more help and experiencing some higher levels of anxiety and depression, but also really demanding that they want the help and care they need.
The particular study I described was in a region of the world which is very poor and had the added difficulty of a major earthquake several years ago. This is Haiti. And so there was a devastating earthquake, 200,000 people died. Kids were displaced, kids lost parents. And so most of these youth in our study who had mental illness were suffering without any kind of help at all. So the goal was to help the teachers help them. And so we trained the teachers. The teachers were great. They were enthusiastic learners, and they also were very good teachers of the research team. The study in Lebanon is different in the sense, it has the same goal, which is sort of the understanding that there's a high mental health burden and there's a real treatment gap, and that schools are an excellent platform to try to close that gap. So the goal of that program is really to have an intervention which is more in the form of a health curriculum that would then teach the kids, the student participants, to manage better with some of the stresses that they encounter and hopefully reduce the burden of anxiety disorders, depression.
I would say we all have to work towards social change to try to prevent those things from happening. So I don't think of resilience as accepting injustice, accepting abuse, accepting sexual abuse or domestic abuse. Resilience is about accepting the experience that's happened already and making meaning of that, changing your relationship to it, not letting it define you, not letting it keep you broken, but finding ways to be stronger in those places where you're broken, using those experiences to learn. And I think when people are resilient, they also use those experiences to say, I'm going to make this better for somebody else so this doesn't happen again, or I'm going to work for peace in my country. I'm going to work to eliminate or change terror or abuse or sexual abuse. So, my view of it, it's not about accepting the event or accepting the status quo. It's more about accepting the past experience, making meaning from that so you can change.
One of the speakers today mentioned about the contextual importance of, how you define something that's abnormal. And in some societies, something that's regular, normal, is viewed as abnormal in another context or another society. So I think we have to keep an open mind, and really, in my view, I think anything that's pathological means that it's something that's harmful. If it's harmful to the person, it's harmful to the community where they live, then it's something that we need to address. It may not be necessarily something just different. So difference is not abnormal.
Oftentimes there's no bright white line between abnormal and normal. Sometimes there is, but for many behaviors, everyone gets sad, but when does sadness turn to depression, right? For eating disorders, which is my field, sometimes everyone eats too much, and when does eating too much become a pattern that is a clinical problem? And generally speaking, we would say that to be a mental disorder, it has to cause distress or impairment, right? It has to make a difference in that person's life. And if somebody is, is behaving in a certain way, but they're functioning fine, and school's fine, work's fine, home's fine, social function is good, then it's very difficult to make the case that there's a problem there.
Well, as I said in the presentation, I think being a human being is about suffering. You mentioned the refugee crisis. We all have experiences, even when we don't have those kind of political events. People we love die, we get sick. Humor it's an anesthesia for that reality. It allows us to see something kind of funny and joyous even in some of the most difficult circumstances. And big fan of Claude Gabran. He has an essay on the tear and a smile. And I think when you truly grieve, that also creates space to truly laugh. And those things, they go hand in hand. And so sorrow is always wedded with joy in my view.